Good evening, everyone. Thanks for giving me this opportunity to talk on nuclear medicine diagnosis and therapeutic aspects in thoracic carcinoids. Uh, as far as the carcinoids are concerned, we have typical carcinoids, which constitute almost 1 to 2% of lung tumors. In addition, 5 to 15% have around lymph node metastasis at presentation, and 3% have distant metastasis. Whereas the atypical variants represent 0.1 to 0.2% of the lung tumors, and almost 40 to 50% of these have lymph node mets at presentation, and 20% present with distant mets. So if you look at the disease survival rate overall, the atypicals fare much worse as compared to the typical carcinoids. Next slide. This is the general algorithm for seeking the diagnosis of pulmonary and neuroendocrine tumors. Basically, this is the system of how to reach a diagnosis, where you first start with a contrast CT of the chest, and then depending upon the pattern that you see on the scan, you go ahead with a bronchoscopy, or if the lesion is accessible, you can directly go for a histopathological diagnosis. If you want to look at the metastatic evaluation, you can go for a whole body scanning like rotated PET CT. And if you have a diagnosis which is sinister, then you can add an FDG PET to it. Next slide. As far as the current treatment options that are available to us, somatostatin analogs are commonly used, as has been described or discussed by Dr. Sunil, and which was published in the Luna trial. This was a phase 2 randomized study with lung and thymic nets, which was a 3-arm study using pasireotide, everolimus, and combination of both agents. And it showed a 39%, 33%, and 59% disease control rate in each of these 3 arms. The sinister part was the adverse events, which required a dose adjustment or interruption in 24%, 52%, and 61% of the patients respectively. Next slide. Coming to the nuclear medicine aspects, currently we have what is known as somatostatin receptor specific PET imaging, which is known as gallium-68 dotatate PET CT for detection of pulmonary carcinoids. What happens is we do a whole body scan in this case, and these nuclear tracers specifically bind to the somatostatin 2 receptors, 3 and 5 receptors. So we have something known as a radionuclide, which is gallium-68, which is bound to the peptide, which goes and localizes to the somatostatin receptors. As you can see in this image, basically we have a physiological localization of tracer in the liver, the spleen, the excretion of tracer to the kidneys, and a faint localization in the pituitary gland. What we can see is a prominent focal uptake marked by the arrow in the region of the thorax, which corresponds to the primary lung carcinoid. So this is the intensity of uptake, and when we calibrate this intensity against the uptake at the physiological sites like liver and spleen, we can easily say that the uptake is equal to the spleen. So whenever the uptake in a lesion is more than the liver and spleen, we call it as a positive scan. And as we see here, in this patient, we can see that the carcinoid is strongly picking up the tracer. So this is how gallium helps in diagnosing or picking up carcinoids, which are often innocuous on conventional imaging like CT scan. Next slide. Coming at the diagnostic classification, pathological classification, Rajiv has already elaborated. Basically, the whole crux of the diagnosis relies on the extent of mitosis and the necrosis, which we see. And depending upon those features, the carcinoids have been always classified in a very conventional and a conservative manner as typical and atypical carcinoids. Next slide. Now I'm going to discuss the rest of my talk citing a few of the cases, because my talk relies more on the images. We start with the case of a 46-year-old male who was a BD smoker who complains of breathlessness since 2 months, and FOB showed growth in the left main bronchus with extrinsic compression of the left main bronchus, and the biopsy was typical carcinoid. Click please. This is the dotatate PET CT, which shows an intense uptake on the left side of the thorax. It is quite a large lesion, One more click, please. As you can see on the CT, there is a large mass in the left hemithorax. It is a heterogeneously enhancing mass which is encasing the vessels, invading the mediastinal, pushing the central mediastinal structures. One more click. And there is intense uptake that is seen in this mass, which is confirmatory that there is presence of somatostatin receptor avid disease, and thus this is a carcinoid. Surprisingly, the imaging features were not classical for a typical carcinoid, where you see a very well-rounded, well-defined lesion, and which does not really encase or invade the surrounding structures. So this is a typical carcinoid as proven. However, the features were suggestive of a very sinister pathology. Next slide. Well, so how do we use gallium dotanol PET CT? As has been shown in this publication, nearly 10%, 10.2% of the typical carcinoids show distant metastatic disease. So this is the increment that whole body imaging provides us when we are using whole body PET CT with somatostatin specific tracers. And also the SUV max on FDG PET. When you add an FDG PET in addition to a dotanol PET CT, I will be coming to it in the later slides. The SUV max is much higher for FDG as compared to DOTA when we are using it for imaging atypical carcinoids. Next slide. So now, when should you use FDG PET in addition to a dotanol PET CT? Next slide. Now, there are theranostic implications when we are using two different types of tracers. When we extrapolate the information that we have from GEP NETs, where there is intense tumor heterogeneity, and as a result of which in the grade 2 zone, where we have a broad range of 2 to 20% of MIB index, we often use DOTA as well as FDG PET in order to decide the management strategy. Now, in one of these publications, which included 56 patients, 34 of them being atypical carcinoids, distant metastasis was seen in almost 94% cases of atypical carcinoid, and 50% patients with atypical carcinoid showed FDG positivity. So this makes a strong case for adding FDG PET to DOTA PET CT, especially in cases with atypical carcinoid. Next slide, please. Click. So now we come back to our case again, where we have intense uptake seen in the left hemithorax, a large lesion which is encasing the superior and the middle mediastinal structures. Next click. Now this patient received 4 cycles of PRRT and showed stable disease. There was some kind of symptomatic relief. Mild increase in uptake was seen. There was no increase in size as far as RECIST was concerned, and there was no sign of distant metastasis. Now, since the disease remained stable with some amount of increase in metabolic activity, we thought, and the imaging features were not very classical for a typical carcinoid, we thought, why not do an FDG PET? So we added an FDG PET. One click, please. And this is what we saw. There was an intense uptake seen on FDG PET as well. So there was an element of tumor heterogeneity. So when we take a biopsy in cases of carcinoids, it also depends on what sample we have. And we can clearly see here, there are areas which are showing de-differentiation in the form of FDG uptake. Mind you, this is a case of typical carcinoid. So this is how imaging heterogeneity really helps us and can change the management even in cases of typical carcinoid. Next slide. Now, what do we have to offer when there is an FDG uptake? So we have capecitabine temozolomide, which we have extrapolated from GEP NETs. And this is the study which was published by the Moffitt Cancer Group, which showed that 16 patients of these 20 patients, which had multiple prior lines of systemic treatment, showed a decent PFS and median OS. Most importantly, the toxicity profile was mild with mainly grade 1 expected toxicities, and 6 patients required dose reduction because of toxicity. Next slide. Now I come to my next case, which is a 32-year-old female who was evaluated for fever and cough. CECT was done, which showed a left lower lobe lesion with endobronchial extension, mediastinal lymph nodes, and liver lesions, which was diagnosed as an hydrated cyst elsewhere. Patient underwent a left open pneumonectomy in Jan 2022, which showed a NET grade 2. Well, next slide, please. Now these were the features that were seen. It was again a typical carcinoid, but necrosis was not seen. MIB labeling index is 4 to 5%. Next slide. This was from the pneumonectomy specimen. However, when a repeat biopsy was done at TMH, it came out as grade 2. Now, this was the DOTA-TATE scan. Now, mind you, the lung lesion, a pneumonectomy has already been done. And in spite of that, these are all the distant metastatic sites. Now, there is intense disease in the liver. There are multiple sites in the marrow and the skeletal system. And so, this actually is showing very high burden of disease. Next slide. Now, this patient was going to be referred for PRRT, but before going ahead with PRRT, we decided that considering the disease burden, the diagnosis of typical carcinoid really doesn't match. So let's do an FDG PET as well. So an FDG PET was added. One click, please. And this is the FDG PET. Now the uptake in the liver lesions is much intense on an FDG PET as compared to what we see on DOTA-TATE PET. The skeletal lesions may show faint uptake as compared to DOTA-TATE. So you have a inherent tumor heterogeneity, which we are seeing here, where we are seeing liver lesions which show a dedifferentiation as compared to skeletal lesions which show a well differentiated component. One more click, please. And the local site in the paraspinal region, we had a recurrent disease which was DOTA-TATE avid. One more click. Next slide. Now, how do we use PRRT? Do we have enough evidence, or the evidence is still sketchy? Well, I would say that the evidence is still sketchy, and we have been just extrapolating from what information we have on GEP NETs. Now, this is one of the robust studies that I have read across the entire literature, and it shows that in 48 patients, of which 43 were atypical carcinoids, and almost all the patients were treated due to disease progression. As you can see here, the response assessment was done on metabolic criteria. So gallium SUV was used as a marker for assessing response in addition to RECIST. And in patients who had stable disease on RECIST, but who showed response on metabolic criteria, there was a definite improvement in survival as compared to the other counterpart. Most importantly, most grade 3 or 4 adverse effects were reversible, and the most common was lymphopenia, with no incidence of myelodysplasia or leukemia, which has often been reported in patients with radionuclide therapy. Next slide. So now, what exactly is PRRT? Well, we have. I'll start with what exactly is gallium DOTA-TATE PET-CT. So gallium-68 is the radionuclide. The peptide which we use is octreotide, basically named as TATE, TOT, or TOC or NOC. So we need something to link those two, and that is DOTA. So this name is gallium-68 DOTA-TATE, DOTA-TOC, or DOTA-NOC PET-CT. One click, please. One more. And when you flip this gallium-68 with lutetium-177, so the rest of the part remains the same, whereas you are just changing the radioisotope from a diagnostic one to a therapeutic one, and you are targeting the same receptor. So this is how we use PRRT. When we have a positive expression of somatostatin receptors on the lesion, we can use the same therapeutic counterpart to target it as a therapeutic agent. Next slide, please. So I'll end my talk with this last case where we have a 52-year-old female complained of low backache. Patient had a broad-based pleural and right lower intrathoracic lesion and multiple ill-defined lesions in segment 8 of liver. CT-guided biopsy was suggestive of a neuroendocrine tumor grade 1. It was a paraspinal mass, MIB index of 1 to 2%. Next slide, please. Now this was the lesion. There was a large mass, multiple liver mets, and a right lower lobe extremely DOTA-TATE avid mass. Click, please. Now this patient received 4 cycles of PRRT. Mind you, this was a typical carcinoid with metastatic disease. This patient also had an isolated bone lesion in the left iliac bone. Post 4 cycles of PRRT, this is the result that we have. The liver lesions have shown complete response. The skeletal lesion has further reduced. This patient was again repeated on PET-CT. Gallium DOTA-TATE PET-CT was carried out after 3 months, and we show that there is a complete metabolic response, almost complete metabolic response. And then we referred this patient for potential surgical resection. So this is one neoadjuvant intent of treatment of PRRT that we use in a case of typical carcinoid. Next slide. Well, the evidence is sketchy, but the results are quite encouraging. So the take-home message is that somatostatin receptor imaging with dotatate PET-CT is recommended in cases with bronchopulmonary carcinoid. FDG PET can be added if histology shows an atypical variant. And PRRT is safe and efficacious therapeutic option for locally advanced and metastatic lung carcinoids. Thank you very much for your patient listening.
Thank you so much, sir, for this crisp presentation. Sir, we have two questions. One is in the question answer box by Roshni Pandey ma'am. How to decide regarding re-SSR analog versus PRRT?
Okay. So I would say that your decision making should, at least in India, the decision making is based on cost. If I have to say, because LAR today you have to give until progression, whereas PRRT is 4 cycles, and so the cost is much less. At a scientific level, currently there is no evidence as to which comes first and which comes next. If we extrapolate what we have from GEP entities, then you start with LAR, then move to PRRT as a re-challenge or a option in the refractory cases. Or if you have a high disease burden where you feel that you need to address the aggressive nature of the disease, then you can go ahead with upfront PRRT first. So this would be my take on this question.
Oh, okay. Thank you, sir. And sir, one more question. Can we use DOPA PET in place of DOTA PET, and the difference between the two, DOPA PET and...
Yeah, so DOPA PET is an amino acid. Basically, it is it is a tracer which targets the sympathoadrenal system. So it is more specific and sensitive for neuroblastomas, pheochromocytomas, tumors which follow the sympathoadrenal pathway. Tumors, of course, those tumors also have somatostatin receptor expression. Whereas dotatate PET-CT is more specific for neuroendocrine tumors which have intense expression of somatostatin receptors. So gallium dotatate PET-CT is definitely preferred investigation of choice for neuroendocrine tumors. And DOPA PET-CT is preferred in patients which follow the sympathoadrenal pathway, something which is similar to an MIBG scan for neuroblastomas, pheochromocytomas, and paragangliomas. So that is the answer.
Okay, thank you so much, sir.